This may seem like a controversial question, but essentially I'm asking, are the vaccinated more at risk of COVID infection and therefore COVID complications? This may seem counterintuitive. Why in the world would they be at higher risk? They've been vaccinated. Well, first you have to understand the science, and then I'll take you through what I think is the explanation for why this science is relevant and why this is critical for us to understand. I'm Dr. Philip McMillan. I've been focused on COVID since early 2020. I've published papers around autoimmunity and the mechanisms related to spike protein autoimmunity. And so I've always had concerns about what is happening in the pandemic and the longer term implications. You may think that the virus is very mild now. It's mild in the sense it's not causing severe COVID, but it doesn't mean that the infection is mild. So before we start, I'm just going to remind you about coming up in another few days is going to be a discussion around gluten and the gluten intolerance, the epidemic you never knew about. You may not realize this, but this is actually directly connected with what's happening in COVID. And gluten intolerance is going to get worse. If you are having any gut related issues, you're not quite sure what's going on, pretty good chance that it could be driven by the gluten issue. And it's really fascinating as to what has been happening since about 2002. But if you're interested in the science, join me on the webinar. You'll see the link in the description below. But let's get back to some basics about the science in relation to what is going on with regards to COVID 19. You have to remember SARS-CoV-2 is not a typical virus, whatever anybody may tell you. This is why so many people have died across the world. This is why they're struggling to be able to control the spread of the virus. And it's largely because there hasn't been a good focus on understanding really what is going on. I'm going to give you some insights. Now, remember, this is my information. No need for you to trust it. You can trust and verify yourself. But here is why I'll be explaining what my take on the science is. So let's start with a few basic things. This is essentially what happens in terms of an infection. This represents the virus, and the virus has on the surface these blue spike proteins. And then there are some other red and orange dots that represent the envelope and M proteins. And on the inside of the virus is the nuclear capsid protein. And these are the things that the immune system normally targets. What then happens is that the virus gets into the upper airway, it infects the upper airway, then it starts to spread in the upper airway and then spread down into the lungs and into the bronchioles here. And that's when it gets to the lungs. Now, we are at a different phase in that Omicron is not as dangerous to the lungs as, say, Delta. Delta used to go all the way down into the lungs. Omicron tends to stick more in the upper part of the airway, in the bronchioles. It still causes infection, but a different kind of infection. Here is the point. Infection of the upper airway is not so much a big issue. Because if your immune system is able to handle the infection quickly, symptoms resolve. What we are trying to avoid is the virus breaking through the immune system and getting into the systemic circulation. That's the serum viremia. This is what triggers the antibody response in the bloodstream. Really important point here is that essentially one of the things that everybody has been exposed to the virus. And so those people that you hear talking about, I've never had COVID, what effectively they mean is that they have been exposed to the virus. The virus has had limited replication in their upper airway, probably because they had prior immunity to any coronavirus or a rhinovirus, and it wasn't able to evade interferon. And so they had a localized upper airway infection that may have caused mild or no symptoms, but they have been exposed. And critically, those people didn't have the virus breaking through into the systemic circulation. Those are the people who, if you checked their blood, they would have no antibodies to the virus. And we say, therefore, they haven't been exposed. Well, that's scientifically impossible at this phase if they are existing in the world around other people because Omicron is so transmissible. What it has meant is that they have an airway infection that hasn't penetrated their mucosal barrier. Now, this is such an important point, and so very few people forget about it. Your immune system is not just about your systemic immune system. So, say for instance, your skin is also an immune organ. If I peel away the layers of your skin, bacteria will be able to get underneath into the submucosal layer and cause infection. So the physical barrier of the skin is also part of your immune system. So that's another type of immune system. It's just that in the upper airway, there isn't a skin, but there is a very sophisticated immune defense mechanism. And this is where they have all these cells, they have these cilia on top of them. They have mucus to prevent the virus from getting in and infecting the cells. It's being produced by these cells. And then, even if the virus infects a cell, and tries to spread it, it will then try and spread below here, where it comes across a very sophisticated immune defense, which then prevents the virus from breaking through this mucosal layer. And so, therefore, this category of individual who has a very sophisticated or very good active mucosal defense will appear as though they haven't been exposed to the virus. Okay, that's the first phase. So, here is the important thing is that just because you've had an infection in your mucosal layer doesn't mean that it's necessarily serious. Really important point. So you may have the infection. The hope is that you don't transmit it and everybody is okay. Here is the important piece of the puzzle that I'm highlighting here now. It's what I call viral sepsis or a serum viremia. So what then happens is if the virus then breaks through your mucosal barrier, it passes through the lymph nodes, it gets into the bloodstream, it can circulate in the bloodstream, and because there's ACE2 on the surface of endothelial cells, it can infect these cells, continue to replicate, and then your immune system is fighting to catch up. And what I consider this like is that so even if you had antibodies, they are fighting to keep up with the infection. And in the process, they can damage the cells by fighting against it. And so you can imagine your CD8 immune cells, if there is a serum viremia, will kill these endothelial cells. But in the process, they will damage the lining of the blood vessel. And this is likely to be one of the mechanisms that we're seeing abnormal clots, where it's a critical phase of clotting is that you have to have damage to the lining of the blood vessel. So it's that kind of situation that occurs, and that's what I'm talking about, serum viremia. Not simply an infection of the upper airway, but it's whether or not that virus breaks through into the bloodstream. Now, why would I think that this is more likely in the vaccinated cohort? So there are two phases to this. The first question is, are the vaccinated cohorts more at risk for infection? That's the first question. Now, I would say that it seems to me pretty obvious from just real world observation that COVID is circulating in highly vaccinated regions. So that would indicate that, well, if the majority of people in a region, say Portugal has almost 90% or 95% vaccinated, including children, if you had a situation like that and the virus is circulating, the chances are it's not just circulating in the tiny amount who are unvaccinated, it must be circulating in the vaccinated as well. So the first point is that okay, we can accept from just purely real world observation that COVID is circulating among vaccinated cohorts. And that's not surprising because the vaccine didn't prevent transmission in the sense that it reduced the risk initially, but it didn't stop it from occurring. Very obvious for us to have. So the next question is COVID circulating in the same way in low vaccinated regions? So I've used places like Papua New Guinea, only 5% vaccinated, or parts of Africa who didn't really get some of the vaccine, or some of the third world countries. Well, what we seem to be happening, and this is from people's observations on the ground because they make the comment, they don't have circulation of COVID really. It's not happening anymore. And this would make perfect sense based on how the immune system works. A lot of people don't grasp that the natural immune response is very different to the hybrid immune response. And I'll give you a simple example. When they looked carefully at what occurred in natural immunity, when a person was infected with the virus, and some people would argue, why take the risk of dying in order to know this? But we didn't have the vaccines at that time, and we knew who was low and high risk. Anyway, the point is that what then happens in the natural immune situation is that when the immune system is faced with this virus, interestingly, it doesn't target the spike protein so much. Of all the immune epitopes, and epitopes meaning parts of the virus that the immune system is targeting, only 20% of them are on the spike protein. 80% are on other parts of the virus, including the nucleocapsid, the membrane protein, the envelope protein, and critically, the proteins that the virus makes after it infects a cell. There are some ORB proteins, and that actually is where the natural immune system targets. It's very interesting because what it indicates is that these proteins are only inside cells. They're not floating around in the bloodstream. And that means that the natural immune system is not targeting the virus with antibodies primarily. It's primarily using CD8 T lymphocytes to kill the virally infected cells. And so that's a very important difference. In hybrid immunity, it's primarily producing antibodies against the spike protein and specific parts of the spike protein. And one of the problems has been is that when you skew the immune response to the spike protein, which is what happened in many parts of the Western world because there were spike-based vaccines, is that it doesn't necessarily follow the same natural process as natural immunity. So someone would say, well, does it matter because once someone then gets an infection, don't they go back to essentially having natural immunity? No, and this is what part of the problem is that the immune response is still skewed towards the spike protein. And then that spike protein keeps on changing. And that changed spike protein keeps on confusing the immune system and it is delayed in responding to Omicron. Now, this is not the same for everybody, okay? In everything in life, there are cohorts of people. And so, even within the unvaccinated, there are cohorts of people who have a weaker immune system because of interferon autoantibodies. They will tend to get recurrent infections as well. And that's just because their immune system is not responding to the virus. Within the vaccinated cohort, there are going to be people who had exceptional natural immunity or mucosal immunity beforehand, which wasn't particularly affected by the vaccine. They will also be protected. And those are the people who will tell you, well, I've been vaccinated. I haven't had any problems, no issues. But there are a cohort within the vaccinated group that are likely to have skewed immune responses to the spike protein. We don't know how big that cohort is, but the mere fact that the virus is still continuing to circulate so highly, it would suggest that it's not as small as we would like it to be. Now, I just recently done a presentation about encephalitis, and you can look through the videos to see that. And the presentation or the paper was looking at the fact that the individuals, or the individual, it was an 84-year-old gentleman who died, they thought it was vaccine related. My feeling was that it actually was the combination of the two: immune priming from the vaccine and then an infection that caused the encephalitis. Now, in this context, he would have needed to have a serum viremia in order to have the complications. And that's really what I'm focused on. And so you can see here, this is what I've used as the brain inflammation secondary to viral sepsis. So what you would then have is the virus is circulating, it's infecting the endothelial cells in the brain, in the blood brain barrier. Then, because it damages these cells, the immune response, blood and immune cells can get in, and then it causes inflammation in the brain. And so, this is where the risk lies, where the virus is floating around and therefore causing problems. Again, people may argue that this is purely speculative. It is no evidence that this is necessarily the case. Well, what I would say is that actually we do have some evidence in terms of what happened in terms of the Cleveland Clinic. They did some important research here about the effectiveness of the coronavirus bivalent vaccine. And they were looking at infections in terms of following their healthcare cohorts, up to 50,000 people. And 0 doses, 1 dose, 2 doses, 3 doses, greater than 3 doses. That's therefore in terms of time, the days since the study was started, but critically, the cumulative incidence of COVID 19 infection. What you can see here is that as their doses went up, their incidence of COVID went up as well. Again, that makes perfect sense in the real world. Now, it doesn't mean they had severe COVID, and this is where they would argue that the vaccine protected against severe COVID, but their risk of infection seemed to increase. And this is now mucosal infection. What we don't know is we don't know how many of that cohort would have then had a serum viremia. That's what I mean. Now, remember, an infection in the upper airway, where it's localized to the immune system, a mucosal immune system, is unlikely to cause significant problems. However, once the virus breaks through that and gets into the systemic circulation, that's where the risk happens. And the essential takeaway from that paper is that the risk of COVID 19 also varied by the number of COVID vaccine doses previously received. The higher the number of vaccines previously received, the higher the risk of contracting COVID 19. This is a quote from the paper, by the way. This is not just my opinion. And so that fits in the context of what we are seeing. And part of that reason is likely to be related to IgG4. There are a couple of things, and I can't go through all of them because every one of them is a presentation on itself. But the principle is that the two factors that I think are occurring: one, the immune system is skewed. And just to make it clear about this skewing of the immune system, again, this is not me making it up. This is what the science shows. In this paper published in 2023, they were looking at the immunogenic epitope and protective antibodies against the furin cleavage site of SARS-CoV-2. And essentially, what they were finding is that the strongest antibody response, or the strongest immune epitope, targeted the furin cleavage site of the virus. Now, that's really good in the sense of the original variants. because all of them use that furin cleavage site. This is the thing that coincidentally is patented and also makes the virus so infective. But anyway, so this furin cleavage site, the antibodies target it and therefore block infection. That's good. But it doesn't work for Omicron because Omicron doesn't use the furin cleavage site. And this is part of the reason that I think that the vaccinated cohort with a spike protein targeting of the furin cleavage site struggle to control an Omicron infection, because that entry mechanism with that variant or all the Omicron variants, it's kind of like the original variants use the front door with the key using the furin cleavage site. Omicron is the type of virus that takes a slower entry. It jumps over the back fence, climbs up the wall, and goes in through the back window. That back window is always open, and so therefore you can't control it. That's essentially the difference. And so you then have a skewing of the immune system towards the spike protein. And that wouldn't occur with natural infection because it's targeting different proteins, the ORB protein, the nucleocapsid protein, the envelope protein. So the natural immune system is more versatile at getting around the variants. And, actually, just to make this point, I think I have a nice picture that I tend to use to emphasize this principle. And this is the original Wuhan variant. She looks lovely with orange hair and orange shirt. The immune system is looking for this. Now, what it doesn't do, it seems, in the vaccinated cohort is that it doesn't pick up purple because it has been told that she's orange. And so, even though she looks exactly the same in purple, it will miss her. And that's essentially what I think is one of the problems with regards to the vaccinated cohort. They are not as effective at being able to differentiate these variants of Omicron because they are so focused, immune refocusing on this Wuhan the variant. And we have seen this before in the sense that we have seen similar types of things occurring with, say, dengue infections. If your immune system is focused on the original variant it faces and then it faces another variant, this is then what can increase the risk of dengue hemorrhagic fever. So this kind of thing can happen, and so this seems to be part of the reason why it's occurring. Additionally, in the middle of all of this is IgG4. And here we have, with regards to IgG4, this one is showing, this is a study about the class switch to IgG4 antibodies after mRNA vaccination. And essentially, it's showing what happens when somebody has an infection and then is vaccinated. And you can see here, blue is IgG1 and yellow is IgG4. The IgG1 tends to be targeted and helps your immune system to get rid of the problem. IgG4 is a tolerant like antibody where it tells your immune system not to respond as much to the specific antigen. And you can see that here, when somebody had an infection and then were vaccinated, you can see that their IgG4 is about 9.3%. And you have to compare this to somebody who already had natural immunity. Their IgG4 is 1%. So this is already 9 times more IgG4. When you then have RNA, then infection, we're talking about 41%. So this is 40 times higher IgG than a normal convalescent patient. If you have mRNA and no infection, it's 45.7%. So this then has an impact on skewing the immune system from responding. And so this is the other reason why, based on the science and a simple extrapolation, as I said, the real world evidence, the fact that we've seen studies showing increased infection with the higher doses, and then we add on top of it IgG4, yeah, it makes sense. Then there is one other thing that makes me think that this is very relevant. And this was from a paper that was done in 2022 about high viral loads. What drives fatal cases of COVID 19 in vaccinees, an autopsy study. This was one of the first studies looking at autopsies after people had been vaccinated. It was critical. And when we looked at it, they compared the vaccinated to the partially vaccinated to the unvaccinated. And what they identified here was a significantly increased rate of generalized viral dissemination within organ systems in vaccinated cases versus non vaccinated cases, 45% versus 16%. So, this is like a 3 times higher risk of viral dissemination. Now, as I said, I'm not making this up. This is just the science. Everything fits. And so, therefore, here is the point that I'm trying to make. It's a simple point. When we look, therefore, at the COVID complications going forward, my concern is that it is more likely to occur in a vaccinated cohort who has a skewed immune response and therefore is more likely to have a serum viremia, where the virus is circulating through the bloodstream and therefore disseminating into multiple organs. Once the immune system starts to respond to the virus, it will then target whichever organ is affected. If it is the heart, they will get a myocarditis because of the immune system. If it is the brain, they will get an encephalitis. If it is the lung, they will get lung inflammation. If it's the kidney, they will have worsening kidney function. And that sequence of events is primarily around whether or not the virus has broken into the bloodstream. And my point is simple. Based on the science, based on the observations, this is more likely, not only, but more likely to occur in vaccinated cohorts. What we need to do is stop playing around with the politics, focus on the science, because at the end of the day, everybody, whatever your vaccination status, your friends, your family, your co workers, you don't want them sick. Please, we just need to concentrate on how to protect them in the longer term from ongoing infection. That's essentially all I'm saying. And I don't need to get into the politics of it. But the problem is, the reason it's become political is because there doesn't want to be an acknowledgement that the actions taken in the pandemic could have actually put certain groups at higher risk. They don't want to acknowledge that. And therefore, in order to protect themselves, they will rather to ignore the science, ignore the concerns for their own benefit. You do not want those kinds of people looking towards your scientific well being and health well being. That's part of the problem. And so, this is the reason why I think in the USA, there is a complete flip around in terms of who is likely to be leading the way forward. And it is simply because those people who were in positions of power, who should have known this and should have been willing to stand up and say, whoops, let's look at this again, let's address it, let's move forward. I acknowledge I didn't know this. That is not happening. And therefore, they are putting everybody at risk. Just remember this. It doesn't matter what your status is, because as I said, this risk is higher in certain cohorts, but the risk is to everybody. It just takes for your immune system to fall off for whatever reason. You're under stress, you've had another infection and your immune system has fallen off. You are then at risk for an infection with serum viremia. That's the reality. So we are all in this together. But we do need everybody to acknowledge where there are issues. Without that step, I think we're going to continue going in circles. I'll keep on asking the questions for as long as I can. So, in summary, remember, the serum viremia is the big issue that we all have to worry about. We have to find ways to prevent it, but the first step is to acknowledge the reality of it. As a final reminder, look in the descriptions. Remember to join me on the gluten intolerance, the epidemic you never knew about, and I'll explain why this is going to get so much worse after COVID. Important information. Hopefully, you've got benefit from it. Have a great evening.